Just- First and second toes, short sternum, then atlantoaxial instability, hip dysplasia, and then joints dislocation. Then comes the cardiac clinical features, endocardial cushioning defect, most common in this one. And then we do screen at birth for all of them. Then VST, AST is very common, PDA is common, and then the pulmonary hypertension. So we do screening at birth for all of them. And after that, we don't follow up, just screening at the birth time. Then comes the facial one, brachycephaly, up slanted, apicanthal folds, three fontanelle, flat nasal bridge, short hard palate, microcephaly, low sat ears, hearing loss, or otitis media. So because of hearing loss, hearing screen at the birth, and then it's basically done it annually. Then the hematological findings, which one ALL and AML is there, so that's why screen at birth. Endocrinology finding, so hypothyroidism, hyperthyroidism, diabetes mellitus, and then infertility, obesity is there. So you have to do the screening at birth time, 6 month, and then annually. So please remember the screening of each of them. Then the respiratory finding, obstructive sleep apnea, then respiratory function. So in that case, is screening at every 1 year. Then comes the, sorry, why is this not moving? The neuropsychiatric findings. This is basically hypotonia, developmental delay, autism, and seizures. So screen each visit. So you have to do it in every visit whenever they come. Gastrointestinal finding, in that one there is duodenal atresia, annular pancreas, then tracheoesophageal fistula, Hirschsprung, imperforated anus, neonatal cholestasis, and then celiac. So for celiac, we do screening at 2 years. Then comes the causes. What could be the causes? The mosaic pattern could be there, non-conjugation, and then translocation. So reoccurrence is only 1%. When the reoccurrence becomes 100%, so if the parent has a 21:21 translocation. Prenatal screening or lab finding is basically having low alpha fetoprotein, low estradiol, high HCG, or high inhibin. So at least do keep in your head of the Down syndrome. I put it here for your understanding at which time, which screening that you have to do, and you have to keep it, remember, on your fingertips. Then there is trisomy, and then you can read all of them. So I will share all of that one. So we'll just not waste our time reading all of them again. So let's move on to the next one. So I was talking about this here, endocrinology page number 13. If you can see, the diabetes mellitus and HHS is given here. You can read all diabetes mellitus. You can read only this one. At least read the sidebars. Now we are only going to study the diabetic ketoacidosis and hyperosmolar. So you can read pathophysiology for your understanding. Then how does the presentation present? So the patient is already type 1 diabetes. Then they have some sort of infection, vomiting, pain, anything is going on that can leads toward this decay. So they can present as an air hunger, causes vomiting, pain, Kussmaul respiration, acetone breath, and then precipitating factors could be the infection or newly diagnosed diabetes or thyrotoxicosis and drugs, all of that one. In that cases, in the serum, what do we find is basically blood glucose, sodium, checking for potassium. It could be either normal or it could be either high, then bicarbonate, bijou and creatinine, ketone, then PO4, partial oxygen basically, and then checking for the sodium. So how do you calculate the sodium, correct sodium, that one. Mainly you need to remember the osmolar whatever formula. Other than that, you're good. Be aware of the possible euglycemia. DKA is in pregnancy with those with the SGLT2. So we already discussed about SGLT2 causing a lot of hypoglycemia. A 9-gap metabolic acidosis with a possible secondary pulmonary respiratory alkalosis could be there because there is acidosis going on. So they will try to compensate and come with the respiratory alkalosis. And in positive, in urine, there will be glucose and the ketones. Now comes the most important part. It can be asked in many ways, like a direct understanding of your DK, or it can be asked like whatever the step, what is the next step that you would like to do. So you need to remember after which step, what is the next step. That's very important. Like you have to remember the step by step approach of it. So starting with that, it's basically a emergency. So start with A, B, C, first priority. Then we are going to monitor the anion gap and obviously blood gases, all of that. You have to go with that one, checking for ketoacidosis and all. Anion gap is the most important endpoint used to monitor the resolution of the metabolic acidosis. In that one, we have to start with the fluid intake, like rehydration. How much rehydration? That's not very important. If you still could remember, that's good enough. So in that cases, what do we do is basically keeping 500 ml in first 4 hours and then make it half in the next 4 hours. So you just need to remember what we are giving is basically normal saline because we are wanted this person to be rehydrated. So keep it in your head that 500 ml, let's suppose they give you, okay, 500 ml normal saline has been given. What is the next or step that you would like to do? So in that case, is we're going for normal saline. Uh, so if they ask you what is the next fluid or what is your next fluid calculation, in that case, we're going half of it for the next 4 hours, then switching to 0.45%, and then once the bin, because keep while we are giving and then it can be asked like while giving fluids, what will you check? So we are checking blood gases because we wanted to keep the blood gases reaches 14 and then add the dextrose water. So we have to keep checking if they are going towards the hypoglycemia. So please keep it in your head how you are going to start. We started with hydration, how much, after 4 hours, whatever the fluid is, and during giving the fluids, how much are you going to uh, like what are you going to check? So that's basically blood gases. Now we are already done with the dehydration part. What is the next step? Adding the insulin therapy. So in that cases, you had the insulin but do not use with the hypokalemia, so you have to check the potassium level and then add the insulin. So it can be asked is this way: before adding insulin, what would you like to do, or what's your next step? So in after rehydration, we are going to check the potassium level, then adding the insulin. So don't forget the middle part. Middle part is basically potassium checking and then the insulin. Rehydration, blood gases, where we are checking for the glucose. If glucose is low, then we are going for dextrose water, then checking for potassium and then adding the insulin according to that. Then the maintain on 0.1 in international unit per kg per hour, that one. Then comes the potassium replacement if the potassium is low. So if you get an idea how I'm going with, so we are starting with fluid, then what's the next step, then what's the next step, then what's the next step, and middle wise, what are we checking? Then the bicarbonate is very last part where we are checking and can cause in the cases of the life-threatening hyperkalemia. So in that cases, you have to check. Then again, when we are talking about the HHS, same we have to know what is in the blood gases. You have to check for that one, ketone and all that. Now, if you are talking about the same resuscitation and emergency processes like A, B, C, then again, rehydration. Many of the patients do get better after rehydration, especially in HHS, because they are mainly bedridden or any kind of problem where they are severely dehydrated. So in that case, is giving IV fluid. So did you see the difference between the IV fluid? So in that case, we were giving 500 and later on 250. Here we are going for directly 1 liter. So please keep it in your head. This is very, very important. Then again, checking for the sodium levels and then blood gases, checking for if the glucose is low, then going for the dextrose water. Then the potassium replacement, there is no insulin that is needed in this one. Then the potassium replacement and less where is basically then serum potassium, sorry, serum potassium giving the, if it's low, then giving potassium around 14 equivalent. So then for the precipitating factors, we are checking that one and insulin. So you don't need to remember the doses. You don't need to remember anything. So just need to remember what are you going to give and what are you going to test. Simple. And meanwhile, what is going to, if you are not giving it correctly, what could be the complication? Then in the very end that you are going to give the insulin therapy. So you have to give along with that one and increase saline concentration if possible. So I just wanted to go through here because it's a very important CDM question. But now in your case, it can be asked like a step by step. What is the next step which you would like to do, or what is the investigation that you would like to do in the middle, and these kind of questions. So testing your knowledge about how much you understand about the step by step approach of this one. Okay. Now we can go back to where we were in the family medicine. Let's try to finish the family medicine and we can start epidemiology from tomorrow. Then comes the dizziness. In the dizziness, comes as a west vertigo and in non-vertigo. So vertigo is basically either central or peripheral. The causes are important. Central comes from the brain, so wherever stroke, drug, or tumor. Peripheral comes from the ears, so main ears, BPV, acoustic neuroma, trauma, and drug. Then the non-vertigo, in those ones you have to check what are they having, lightheadedness, giddy, or those ones. Then psychogenic could be there, vascular. In that one, maybe some blood clot is there that is causing it. And then ocular is basically having the visual acuity problem. In that one, checking for whatever the investigation of the choice, and checking for wherever it is coming from. So you keep it in your head if what kind of scenario they have given and what are they looking for. So assess for the gait in the older people, checking for their vision, and test for the neuropathy, especially for the older people. Then the Dick's helping maneuver, please give it a read, how and what is that one. Then the treatment is basically depending on what's the cause, and you have to give the treatment. Then comes the domestic violence, one of the most important topic of this one. In this one, what you need to remember is if a person is getting into violence, in that case is what they need to prepare if any time they have to leave. So that's written here. So if we are talking about everything, we have to ask the history, which one is more prone, mainly females, and then bisexual, 18 to 24 years of the gap. And this is basically violence and physical cognition. Then we are talking about the presentation, how do they present, headaches, gastrointestinal. So, it could be a very vague symptoms and this does not making sense to you. So please keep it in your head that could be a violence. Then maintain an index of suspicious, that if there is an abuse is the strongest predictor. So you have to talk about the patient's safety. Patient feels safe at home, and if there is any children's involved, in that case you have to talk about the children's. Make sure to determine that the victim is level of immediate or the long-term danger. How could it be? And when they go home, how is it going, and what's their access to the weapons? Then ensure the safety. So this is what I was talking about. Victim most at the time of the homicide when attempting to leave or following separation. Like when they talk about separation, then they get even more of the abuse. Then they're talking about if there is a safety planning, includes ensuring that there is access to an exit of the home. So first thing, they should be told that you should have an exit of the home, like a backup exit. Then establishing a safe place to go, like from here, let's suppose if they leave their house, where will they go? Then having emergency items. What are those ones? Money. This is very, very important. Please remember what are the items that they have to take, the emergency items. What are those ones? Money, clothes, keys, medications, and important documents. So the total number five that you have to keep it in your hand, and anytime you can leave. So with you have these items with you. So it can be asked like the items that needs to be prepared. Then provide the community resources, shelter, or the helpline number will help legal advocacy. So, if they leave the home, where will you go? Counseling services, social workers, and all of them, or appointment to follow up and reassure. Then suspected of the child abuse is very important. Then spousal abuse is a criminal act, but we don't report it. We just tell them, document all the abuse, whatever is going on so far. So if they ever, anytime they wanted to report, they can do it. Then we are talking about dyspepsia. In this one, we just have to give PPIs, the lifestyle modification, and giving the H2 and PPIs and TCAs. H. pylori eradication can be asked. So, if there is an H. pylori, what are the most common cause, or how can they present? And along with that, what are the most common complications from H. pylori? So, it can causes cancer and can causes the ulcer as well. So, remember that one. Then their H. pylori eradication, what are those ones? BPMT, and then the one that is non-bismuth one. So with the bismuth, this PPI, bismuth, metronidazole, and tetracycline. So otherwise PPI, metronidazole is the same, then clarithromycin along with the amoxicillin. Then we are talking about the dyspnea, where the breathing is the problem. So usually it's either asthma or either COPD, then along with that pneumothorax, congenital lung disease or malignancy, anything could be there. So you have to see along with that one, previous chest X-rays, PFTs, all of that one. Usually in children, I was talking about, please read Choosing Wisely one time. There is a lot of diagnosis that is supposed to be not done, and it's written in the Choosing Wisely. It will help you to find out where the diseases are clinical diagnosis, and it will save a lot of your time. Then comes the dysuria. Dysuria is like UTI mainly. There is burning sensation, there is leukocytes. Even if the dipstick, there is leukocyte nitrites and dysuria. So usually we start the treatment. Risk factors for the complicated UTI is male, pregnancy, urinary tract instruments, or then anatomical abnormality. So it could be cystitis, urethritis, pyelonephritis. As you can see, the cystitis, it could present with the internal dysuria, nocturia, back pain, suprapubic discomfort. In urethritis, there is internal dysuria, then there is vaginal discharge or history of STI. Then there is vaginitis. In that one, there is dysuria and there is vaginal discharge. Then prostatitis, there is dysuria, fever, chills, urgency, frequency, tender prostate. Then pyelonephritis is basically coming from the kidney, so it has the flank pain. Then the prevention. So always keep it in your head. Good hydration, feminine hygiene sprays avoid. Then the empties immediately the bladder before and after the intercourse, and then the vaginal the estrogen creams. Then history and physical examination, urine dipstick test, urine routines, microscopic culture and sensitivity, and then going for the CBC. In the patient, we do hospitalize if septic or the clinically ill. In that cases, we have to give them the internal treatment where they are not able to tolerate well. The first sign of uncomplicated is trimethoprim, sulfamethoxazole or nitrofurantoin. Usually we do practice nitrofurantoin, a lot of them. And then the UTI cystitis, in that case, we go for the amoxicillin, which is very safe. Even nitrofurantoin goes for them too as well. Patient with a recurrent UTI should be considered for the prophylactic antibiotics, and uncomplicated one, you have to think of broad spectrum one. Then the urethritis, in that case, is giving for the chlamydia and gonorrhea treatment and reporting to the public health. Then the erectile dysfunction. Erectile dysfunction is basically, I already told you that you have to talk about how to approach this case. The psychological importance is very, very, like, you have to do a lot of counseling in this one. And along with that, the treatment as well. Then comes the psychogenic, endocrine, and all of those ones. So you go with the history, asking about, what is going on, their satisfactory reaction, then onset, their sexual activity, how often they get engaged, and all that. Then investigation, checking from where it's coming from. Is it central or is it peripheral? So those ones. Then psychological, psychiatric, then psychosexual, and then relationship, penile transference test, and PTR. Then the vascular diagnosis. Usually we go for psychological. They are mainly the psychological. And usually people like to do either Cialis or either going for the Viagra. So these are the two medications that is very common in using the erectile dysfunction. Then the when are you going to do the referral? That's very, very important. It will help you to write down or choose the option where you have to do the referral. So if you can see, there's a anatomical problem like congenital issue. Then comes the younger patient. Okay, in that cases you have to consider of something what's going on. Then there is a vascular intervention that's needed, complicated problems. Then the psychiatric issues, a psychological one. In that cases you have to do, and then the patient or the physician desire for doing that. So you cannot see that there is no red flag. All is that is not managed by a family physician. In that cases we are referring them to urologist. Then the treatment is lifestyle modification, then the oral and suppository one, then the implants one. So the main treatment you need to remember is phosphodiesterase inhibitors. Then the testosterone we can give, and alpha blockers, yohimbine or whatever it can be used. So usually we go for phosphodiesterase or the testosterone simple. The Viagra, Cialis is very, very common. And then the Vardenafil, I haven't given anyone this one. So usually the Viagra and Cialis is common, and then Levitra is there as well. Then comes the fatigue. Fatigue is very common in the females, especially, and they can do present with vague symptoms. So in that case, is mainly they're psychogenic or psychological, but we do blood work for everything, especially which one? Vitamin B12. So please keep it in your head. The nutrition is one of the most important one. Then comes the other life, sedentary, poor sleep, anything could be there. Then the investigation. So because in the family medicine, the most important is differential diagnosis and your treatment of choice and your investigation of choice. Only three things. At least whichever topic you are reading, try to keep it in your head. What could be the differential diagnosis of that one? Okay, what is the main investigation of choice for certain type of disease? And then what's the treatment for that one? Only one treatment, only one investigation of choice. Please, because they only like to ask one thing. Okay, in emergency medicine, they do like to ask, what is your next choice? Like after doing something, what is your next thing that you would like to do? So these are two different things. Then the psychological causes are important. Physiological, you have to rule out, then checking for CBC, bun, creatinine, ANA, chest X-ray, ECG, serologies, all of those ones. Treat underlying causes and etiology cannot be identified. Validation and follow-up, then the counseling, behavior, group therapy, encourage the patients to stay physically active. Then over-the-counter herbal medication that they can do. Then chronic fatigue is also one of the thing because it can come in the differential diagnosis of fatigue. So it's basically the difference is lasting for more than 6 months, then it becomes the chronic fatigue. Then it's effective. Usually, how do we start the treatment? Please keep it in your head. If someone is coming with the fatigue or erectile dysfunction or whatever it is, if it's not affecting their daily life or if it's not affecting their life, then we don't do any treatment. All we do is reassurance, keeping it in their hand. Usually, it's assumed that someone who comes to the family physician, they are coming because now their life is getting affected, but in some cases they can say it's manageable, it is okay, but I thought I'll just go to the doctor. In that cases, you can do is only reassurance. Please keep it in your head when they say, oh, it's manageable. In that one, they are looking for either you are going to start a treatment or what are you going to do. In that cases, we ask them to keep an eye. So basically, today I saw a patient, what she was having an actinic keratosis on her left cheek. So I saw her, I asked her, she keeps on picking on that one because it gets itchy and all of that one. So I told her she does not need to do the pickiness, and she does what she does is she does a holistic practice. So it can be asked like, oh, a person is coming to the clinic and she's having actinic keratosis or whatever, skin lesion. I was very worried that she might got a cancer, and in those cases, but my supervisor, she said, okay, wait. And because she does not want to see anything or she does not want to try anything because she's a holistic person and does not want to go for medications, so we ask them to keep an eye for 1 more month, and then we'll ask them to follow up with your family physician, and they can put a refer to dermatology. So did you see how we approached this case? We did not give her anything. First of all, we tried to give her, but she was not willing to try anything. In that case, is what we have to do next. Okay. So if the fatigue is not affecting their daily life, we are not going to do anything. If it's mainly the reassurance, keeping an eye, take multivitamins, improve your nutrition and everything. But now it's affecting their daily life. In that cases, you have to see and look for different ways and then starting any medication. Okay. So there is no investigation usually, then the promote sleep hygiene, sport, and non-pharmacological is like a diet, psychotherapy, family therapy, sports. So these are all the non-pharmacological. But when it comes to antidepressant, anxiolytics, NSAIDs, that's when you start. When she's like, oh, I cannot work now, it's affecting my work, or I'm not able to do my 8 hours work what I was doing before. So in that cases, now you can see her life is getting affected. So in the scenario, they will definitely 100% mention it's now affecting their daily life. So they will might not say it correctly straightforward, but they will say, oh, she's not able to do her work how she was doing it before. So this will give an idea that what's going on. Then comes the fever. So we already discussed the fever in pediatrics. Fever of unknown origin is one of the most common fever in Canada. It's many times we are not able to identify, but in many cases, in older people, keep it in your head. The first differential diagnosis for fever is UTI. In younger people, like pediatrics, it is also UTI, but you have to think of tympanic membrane or the otitis media. That is also one of the thing. Okay, in pediatrics, like two different things, UTI as well as otitis media. But in the older people, the main differential diagnosis starts with UTI, okay? And then constipation and all of that one. Because these two generations, they are not able to communicate properly. So in that cases, you have to see what's the diagnosis. So in that cases, that's why I'm telling you, if they says a 75 or 85-year-old male came to you with the fever, in that cases, what's your diagnosis? Usually we start the prophylaxis antibiotic because he or she might be having UTI because they are not able to tell you. Then fever is basically peak temperature, thermometer checking for all of that. Then upper respiratory tract infection, UTI, pneumonia, meningitis, anything could be there based on what are the histories. So pulmonary and then pulmonary embolism could be there. Then gastroenteritis and history of cancer. Please keep it in your head that history of cancer is also can present with only fever. Fever, weight loss, night sweats. Think of cancer. And sorry, old people, 60 plus person, fever, night sweats, and weight loss. please keep it in your, if any of these thing is mentioned in the scenario, it could be cancer. And it will help you to make your diagnosis a lot easier. CBC differentials, then we are going for stool over parasites, culture, chest x-ray, Montutech, sputum, and all of that. Increasing the fluid, sponge bath, and then ibuprofen. Then comes the headache. So these are very vague things. That's how the family medicine is. So usually how they are coming, mainly the answer is reassurance. All you have to do is some test and all of that. If they came out normal, so it's mainly reassurance. But at the same time, you have to see what's going on. Then the headache, in that one, you have to see if it's a trauma. Then we will go towards the concussion and all of those ones, CT scan, where you have to do, where you don't have to do. But if there is no trauma, it could be stroke. So I just recently saw a female, like maybe yesterday or day before yesterday, she was having a headache and she said, I never had this headache before. Okay, but her headache was not as bad that it could lead towards the subarachnoid hemorrhage or any kind of hemorrhage, like hemorrhagic stroke. But she keeps on saying that this headache was really bad. I never had this headache before, but it was bearable. At the same time, she was saying it was bearable. But then I what I did was I checked her blood pressure. I asked her. She was not taking any blood thinners. She had a mini stroke, so told her how important it is at this point, but her blood pressure was normal. There was nothing concerning. She did not have any tingling sensation, numbness, anything on her body. So I ruled out every red flag. And after that, I told her if she ever had this kind of symptoms again, like any kind of this kind of headache again, even a minor headache, please go to emergency right away. So that's how the practice works. So please keep it in your head that, when they put the scenario, what they're looking for, although they're giving you a scenario of subarachnoid hemorrhage, but she had it and she had passed that stage. So what are you going to do next at this point as a family physician? What are you going to do? You can admit, no, you cannot. Are you going to give her medicine? No, we cannot. So all we need to do is, if you are just working as a walk-in, all you have to do is communicate with them and let them know what could they do in the next time. But if you are a family physician, then you do investigations to test her CT scan or whatever, even if CT scan will take a time. Thyroid, even you are a family physician, and if you feel like doing an emergency CT scan, you can send the patient right directly to the emergency and then ask them to do it from there. Then the trauma, C-spine, head injury, then CBC, suspected infection, ESR, C-reactive protein, CT, MRI, CSF analysis to check for hemorrhage or any infection. Then comes the hearing impairment. Please, for hearing impairment, I would suggest please keep it in your head what are the hearing tests for older people and for the younger people. Now we are talking about the conductive hearing loss in the children. The conductive hearing loss is caused by infection, and sensory neural hearing loss in the children's or pediatrics is due to congenital anomalies. And in the older people, conductive hearing loss is due to any trauma, and then sensory neural hearing loss is due to their age or whatever inside nerve or stroke could be the problem. So as you can see, it's a very different things, and this is a straightforward questions. Then the infants universal newborn hearing screening program is there. Then the elderly people, we do this. This was I was talking about, the screening test is whisper voice test in the older people. Okay. Then the tuning fork test and all of that. Then the diagnostic test is then conduction test, audiometry, looking for all of those ones. Then you're going to start with the counseling, checking for whatever the causes is, treating those causes. If there's something sudden hearing loss, sudden vision loss. In that cases, you can give them steroids. I mean, that's what's written in the books. They says treat patient with an unexplained unilateral. So sorry, I forgot to mention unilateral sensory neural hearing loss or unilateral vision loss urgently with the steroid. So you can give her, you can, not 100%, not all the time, you can give them steroids, a high dose steroid, because with the vision it could be the temporal arteritis or the giant cell arteritis. Even giving steroid in that cases can save your vision. In this cases it could be some sort of inside pathology going on, so steroid can save a lot of inflammation kind of thing. So it's a very safe thing to play with, so you can give the steroid. So if they ask in the scenario, this could be the answer. Then CT scan, MRI, and then if it's a like a sensory neural hearing loss, to the vestibular schwannoma. Then refer to the patient to the ENT, wherever you feel like this one. Then the treatment is the hearing aids. Then comes the high blood pressure. I think we have been discussing high blood pressure for so long. Then what is the white coat high blood pressure? That's important. What is the masked high blood pressure is the important. The difference, the diagnosis is important. Okay. So white coat is when they go to the ambulance. Sorry, not ambulance. When they are in the clinic, they have high blood pressure, but when they are at home, there is normal. Then there is a hypertensive urgency, which is more than 210. What is emergency and what is urgency? Emergency is when there is an acute organ damage. In urgency, there is no acute damage, but the BP is very crazy high. Okay. Then we are talking about the white coat. The mask high blood pressure is the normal clinic one with the high BP in home. So it's basically masked away. Then the family history, obesity, alcohol, sedentary lifestyle, smoking, male, age more than 30, salt, black ancestry. Please keep it in your head. What are the diseases that are common in the black ancestry? Okay. Then the dyslipidemia, it could be the renal problem, endocrine, vascular, others or the drug abuse. So you can see on the sidebar, this says the suspected hyperaldosteronism when high blood pressure is more with the treatment. There is hypokalemia, diuretics can be given, and the adrenal adenomas. Hypertensive emergencies, malignant cerebrovascular hypertensive encephalopathy, stroke, hemorrhage, SAH, and all of that. I'm going a little bit fast, so I want to cover at least family medicine today so we can start epidemiology tomorrow. Then the investigations for all the patients, we are going to check for their electrolytes, fasting, HbA1c, like all of the blood work, urine analysis, checking their kidneys, all of those ones. And then the going for the diabetes. Usually in the patient, we do have to look for the aneurysms. So because there are chances of that one. And then if suspected pheochromocytoma, 24-hour metanephrenes and creatinine can be checked. Left ventricular dysfunction, we do echocardiogram. And for the refractory, we have to rule out the. So please, this one. The refractory hypertension, you have to do sleep study because it could be linked with the sleep apnea. Then comes to the how you check for the blood pressure. If there is diabetes, there is no diabetes. In that case, is how you're going to start the treatment. The treatment may increase means the high pressure. So in that cases, you have to do the optimum high blood pressure checking for the mainly diet is one of the things that do control a lot of things. So if a young person comes, please keep it in your head that you know the diagnosis could be hyperaldosteronism, and I have seen recently a patient with that one too. So that one. Then the optimum high blood pressure could be less than 142 or less than 130 with the diabetes. Then moderate intensity exercise can be given. What are those ones? 30 to 60 minutes. Then the smoking, alcohol. So it can be asked how much the exercise could be good for them. Work with the BMI, then the reduced stress. Then pharmacological sports. Pharmacological is like the first line medication treatment, and then the combination treatment if the first line is not working. Then comes this one. What is the first line? Combination of the first line drugs can be used. What are those ones? Single pill, thiazide, or the diuretics, beta blockers, ACE inhibitors. So you have to give those ones based on the systolic and diastolic. You can read these ones. So usually we start with thiazides and then we go to the diuretics, herbs, those ones. So you can see from the side they have written that calcium channel blockers, diaphragm, this one, and this can ACE cannot be given with the what it says calcium channel blocker. It can calcium channel blocker can be given with the beta blockers, and diuretics can be given with the ACE inhibitors. That's what they're trying to say here. So please, if you have time, at least read this one. At least one time, read it. Okay. There is so many nice things written in this table. It will help you to build your concept a lot easier. Okay. If you have time, please read it. Okay, this whole table for heart failure, for CAD, for dyslipidemia. It's an important, at least read this one. For the CAD, we give ACE inhibitors, herbs, beta blockers, calcium channel blockers for the patient with stable. Then recentamide we give with the beta blockers. Then the cerebrovascular disease, in that one we give the ACE inhibitors and thiazide. When we are talking about the diastolic, like only isolated, either it's a diastolic without systolic. In that one, we have to give the thiazide, and then later on, we can add beta blockers, ACE inhibitors, and herbs. Usually, mainly the answer is thiazide, ACE, herbs, and then we go for beta blockers. If there is only systolic hypertension, no diastolic, then in those cases, go for the thiazide. And then remember the heart failure, in that one, we give the ACE inhibitors and beta blockers. For dyslipidemia, we usually does not affect the initial treatment. We have to check the statins and all of those ones. Otherwise, we start with ACE inhibitors for the rest of the cases where the kidney is the problem. So you can see in the pregnancy, the one we always talk about, labetalol is the drug of the choice, and we have to avoid the ACE inhibitors. Then comes the joint pain. So in this one, please don't forget about C3 and C4. That's also one of the link that could be there. Then the warm joints worse with the rest, then with the pain. So basically, this is talking about the inflammatory ones. Awakening in the latter half, redness around the joint, morning stiffness more than 30, and then swelling and erythema. Because you need to know the difference between rheumatoid arthritis and osteoarthritis. They are most important ones. In that one, we do CBC, ESR, C-reactive protein, C3, C4, then ANA, rheumatoid factor, anti-dsDNA, then beta B7, anti-Ro, anti-La, anti-Smith, all of those antibodies, anti-CCP. This is common in the rheumatoid arthritis. So there is a patient that comes with the rheumatoid factor positive, and he's worried that he is having rheumatoid arthritis. Uh, is it common, or what should would you do in this case? So if you don't remember that rheumatoid factor is not the important one in the rheumatoid arthritis, it's the anti-CCP. In that cases, you have to reassure the patient that rheumatoid factor is not the one for the rheumatoid arthritis. We have to do another test to confirm that he has rheumatoid arthritis. So this can be asked in your scenario. Then the Taylor therapy, non-pharmacological, pharmacological. So non-pharmacological rest, lifestyle modification, device, physiotherapy. In the pharmacological, usually we start with acetaminophen, then anti-inflammatory like DMARD, steroids, and all of those ones. Then comes the low back pain. In that cases, is the fifth most common disease, especially presenting in the daily life. The most important is spondylosis, spondylolisthesis. The compression fracture could be there. So please keep it in your older people do have compression fracture, and in compression fracture they do causes the nerve sensation. So you have to rule out the compression fracture. And then when we are talking about the back pain, please cauda equina. Cauda equina should be there in your back pain. Cauda equina is the red flags that you have to rule out. So they would ask you what are the things that you would like to do, or what are the investigation, or what are the disease that you would like to prevent. So cauda equina, back pain is all about cauda equina. Although there is other things, ankylosing spondylitis, whatever, Paget's disease, osteomalacia, and then with the prostate, there cancer, there could be osteophytes too. So, but cauda equina, how I told you, of childbearing age, you have to keep it in your head the beta HCG. That's how the important the cauda equina is. Then we're checking for the inspection, palpation, then range of motion, then neurological examination for the specialty test, straight leg test, and then cross leg, straight leg, and then femoral stretch. I don't know if some some doctor who is very into ortho, they can put us questions from ortho, and especially they do like to put the special test and ask you what could be the diagnosis for that one. Sometimes you do get questions like that where you have to, like, not performing the test, but you have to keep it your head that straight leg raise test is positive in which disease. So it's positive in sciatica. Okay. A cross straight leg raise test is also positive in sciatica, and then femoral stretch is common in radiculopathy. So keeping it in your head, what are the most common ones? Then comes the investigation. We have to check for CBC, ESR, CT, and MRI. Then the back dominant one and the leg dominant one. The back dominant is basically pattern 1 and pattern 2, like looking for if there is problem with the flexion or is a problem with the extension. If there's a problem with the flexion, in that case, we ask them to do extension. If they have a problem with the extension, then we ask them to do the flexion. So for your understanding, all you have to do is they can give you a patient whose pain is worse with the flexion. What's the diagnosis? Is the disc pain. If they have a problem with the extension, what's the diagnosis? It's the facet joint pain. If they have a pain with the movement of the position, then it's basically sciatica, like moving from one to a joint to the going to the next one. If they have pain with an activity and improves with the rest, then this is basically stenosis, like when